all. This is Tom Hutson. I am the editor-in-chief and a practicing GU medical oncologist, as well as the head of the Texas Tech University Health Science Center Cancer Center. And I am joined today by Dr. Marc Matrana, who's professor of internal medicine at the University of Queensland Medical School, Osner Health. Dr. Matrana's clinical practice at Osner focuses on treating patients with cancers of the genitourinary tract, as well as cancer, gastrointestinal cancer, and other malignancies. And Dr. Michael Serzan is a medical oncologist at the Lank Center for Genitourinary Oncology at Dana-Farber. He is an instructor of medicine at Harvard Medical School, and Dr. Serzan has expertise in the treatment of kidney, bladder, prostate, and testicular cancer. So welcome, gentlemen, to what I hope is going to be a very informative lively discussion around one of our great therapies, one of the therapies that has provided significant benefit to our patients with advanced and metastatic kidney cancer, that being cabozantinib. So I would like to just start off with letting you both speak into and answer a question here, just in general terms, in your clinical experience. What makes cabozantinib an attractive therapy for you? About how do you actually select it for use in your patients? Are you using any particular selection criteria, or what makes you want to decide to use cabomedics? And I'll throw it to Dr. Serzan first.
Excellent. Thank you, Dr. Hutson, so much for the introduction and for having me this afternoon. The thing that comes to mind with cabozantinib for me is really the diversity and the breadth of experience that we have with this drug. You look back at CABOSUN was initially published back in 2016, and that's in the clear cell setting, but we have combinations with nivolumab in the first-line metastatic setting, in Checkmate 9ER. We've got the first triplet was studied with cabozantinib, ipi-nivo. We've got cabo-nivo experience in the non-clear cell setting. And so I think what you see there is a real breadth of experience over many, many years. I think a lot of us have used this regimen and know its therapeutic windows and what dose we really need to get control of tumors and to get maximal shrinkage, but also managing some of the toxicities. I think a lot of us our advanced practitioners, our nurse practitioners, our physician assistants are also very comfortable managing this drug as well. And so I really do think about the versatility both in the clear and the non-clear cell setting. When I think about what drug or what combination to pick for the first line clear cell kidney cancer patient, I really think about, does this patient need a response? Do we need to get control of disease? And then you start thinking about subtypes. Do they have bone disease? Do they have brain metastases, where we've seen some really nice subsets showing the efficacy of cabo-nivo in those patients? And then also in the non-clear cell setting as well, do I need to get control of disease? And if that's the case, then cabo-nivo is certainly one of my go-to regimens for that population.
Well, I jokingly want to ask you, is it possible to be at Dana-Farber and not prescribe cabomedics, given your boss, Dr. Choueiri, and good friend, given his involvement with that drug from the beginning? It seems like you would probably, your center there has probably one of the largest experiences using cabozantinib of anyone.
We certainly do, and I think it speaks to the track record of the drug, of the company, of really making a big investment in this space and having some real success there.
So, Dr. Matrana, what do you feel about the availability of cabomedics as one of it's in the treatment algorithms? We see it listed in the NCCN, both in combination, getting category 1 for patients, but then also it's given a category 2, as mentioned by Dr. Serzan, based on the CABOSUN trial as a single agent. Do you tend to use it as a go-to for your patients?
Absolutely, and I would echo a lot of what Dr. Serzan has already said. Extremely versatile agent, really the workhorse, I would say, in many of our treatment algorithms, our treatment regimens that we use day in, day out across different types of RCC. It's an efficacious drug, particularly when it's used in combinations, and it has a manageable toxicity profile, which I think we've all become very acquainted with and comfortable with. In addition, I think, its performance in patients in certain scenarios like bone metastases is unparalleled, right? And of course, the molecular drivers of non-clear cell, I'm thinking about like c-Met, are also hit by this drug. I often tell patients and trainees, that this is a dirty TKI, right? And in many sense, that word dirty is thought of as in a negative connotation. In this connotation, I really think of it as something quite positive. I practice in New Orleans. Dirty rice is a delicacy here. We all love it. It's a terrific food. And in the same respect, a dirty TKI is one that I want to treat my patients because I know that it's going to provide us with more versatility and more efficacy across the board.
Well, before jumping into that dirty discussion and how that maybe lends itself to some toxicity challenges, I wanted to get your thoughts on both of your thoughts on, do you ever feel that using it up front as an initial therapy could potentially be a downfall in the sense that you're not using it in the refractory setting where really it has been the workhorse from the old data from the phase 3 Meteor trial? I mean, I'll have community oncologists will often say, or they'll be polled and they'll say that they like to reserve things like cabometics to later line because they've relied on it so much. What would you tell them to say, hey, no, maybe you should consider it first line?
Yeah.
I mean, I think we've all been there. I think as soon as we get comfortable with the drug and the regimen and data, we're always surprised. And, sometimes a patient has very aggressive disease that progresses despite really effective upfront regimens, and we lose that ability to add it on later on. So I'm a big believer if you've got an effective drug, use that drug early. And certainly I like to start at high doses with my TKIs and kind of dial back, get control of the disease, and then manage, the toxicity down the line. And, I do have patients who are able to get other TKIs in later lines of therapy, more targeted TKIs that are more VEGF specific. But I think, if you lose that opportunity to get control of disease up front, you may miss an opportunity in the later lines of therapy.
What do you think, Dr. Matrana?
The thing is, we have so many therapies to choose from, right? I remember the old days when we had IL-2 and interferon alpha, and that was about it, right? We have so many great therapies to choose from. I'm not concerned that I have to save a therapy for a later line. We have other very good therapies that we can use in the later line. That said, a lot of our patients don't make it to other lines of therapy. So I want to use the most efficacious therapy that I can, the best combination I can up front. And, that's how I explain it to patients. And I think that's how I would explain it to docs in the community as well.
Yeah, I agree. I see, we're all aware of data that's come out both prospectively and retrospectively, where we see almost a 50% decline as one moves from first line to second line to third line. And so that really speaks to wanting to go up front with triplet or quadruplet therapies, whatever it takes to get the job done there. Anyone have any comments for doctors on the Tony Choueiri Cosmic 313 trial, which was a triplet study? In my mind, it was a relatively negative study. It didn't seem to add to it, but I'm always hearing that maybe there's subsets of patients that would benefit maybe from the addition of ipi-nivo and cabo. Let me throw it to Dr. Serzan, because you're up there in the Crystal Palace, I like to call Dana-Farber, with Tony. Do you ever use that off label, or I know it's not on the guidelines?
We do not, but I think Cosmic 313 really helped the field in many ways. It was the first randomized triplet trial. It was the first trial that compared to ipi-nivo in the first line metastatic setting. And it was a positive trial. It did show a PFS benefit for cabo ipi-nivo relative to ipi-nivo. But I think what we learned is that that triplet was too toxic. I think the grade 3/4 adverse event rate was 75%. The dose of cabozantinib was only about 22% or 22 milligrams relative to the placebo, which was 35 milligrams. And a minority of patients actually got the full 4 doses of ipilimumab. And so I think that that combination was very difficult to tolerate and unfortunately did not pay long-term dividends in terms of improvements in the tails of the PFS or OS curves. But I think we learned a ton about how to manage toxicities. You could say if we had that as an unblinded study, perhaps it'd be easier to manage the toxicities of those patients and get them on drug for longer. But I think we learned a lot there. But unfortunately, that particular triplet not ready for prime time. But there's certainly more triplets coming down the pipe.
Sure. And I think when we get down to talk about future directions, we're going to talk about the pedigree trial and the ability to maybe salvage or improve upon responses with the addition of cabomedics. But let me throw it to Dr. Matrana about, he brought up this idea of dirty rice being an attractive thing, and tie that into us in a nice bow as to how that relates to cabomedics and some of the toxicities, some of the advantages, and maybe in overcoming resistance pathways, making it more active, but also that brings in off-target toxicity. So tell us about that a little bit, Dr. Matrana.
Absolutely. So, when you look at, the combination trials, the 9ER study, for example, Checkmate 9ER, a lot of patients were dose reduced. In fact, the great majority of patients were dose reduced. And the average, patient on the study was not on 40 milligrams of cabozantinib. They were on 30, right? And about 80% or so actually had dose reductions. And so I think, if we take that and we extrapolate it into our patient population, I think the most important keynote there is that we have to aggressively dose reduce this drug and dose it appropriately for our patients. The thing is, patients had phenomenal outcomes, great response rates, a disease control rate of 90+%, right, on the 9ER study, but they weren't on the FDA approved 40 milligrams of the drug. They were on 30 milligrams on average, and some of them were on significantly not less. And so I think that taking that into consideration, when I discussed with patients dose reductions, I explained that to them, that patients on the study did really well and they weren't on the full dose. That's the key to managing the toxicities, because you're absolutely right. A dirty drug will get you more efficacy, but it also gets you more toxicity, and you have to balance those two out.
Yeah, and that's great. And so, Dr. Serzan, when I first saw cabo-nivo as a frontline risk, I was actually somewhat concerned myself, kept it internal, obviously, just from my experience. I was one of the authors on the Meteor study, a lot of experience with cabozantinib, exactly what Dr. Matrana is saying, that you go into it telling your patients that there's an high expectation of a dose reduction. It's a marathon, not a sprint when it comes to these therapies. So managing long-term toxicity is important. And I was really surprised at the tolerability of cabo, although at a lower dose of 40 milligrams starting dose, with the combination with nivo. I mean, what's your thought? What's your explanation for that? It's been amazing. I think we've all, as a field, been pleasantly surprised about the tolerability of cabomedics.
Yeah, and I kind of think about the combination. Perhaps there is some synergy where you're getting maximal tumor debulking, and it's easier to tolerate a higher dose of a drug if you've got less tumor in the body and better performance status. But to your point, my first conversation with all my patients who I start on this combination or even cabo as a monotherapy is that. To echo Dr. Matrana's point, that dose reductions or that dose holds and dose reductions are okay. And I say, I'd rather hold for 2 or 3 days, let the system reset, let the diarrhea die down, let the fatigue get a little bit better, and then get right back on therapy rather than pushing things too long and then it ended up being off therapy for a much longer period of time. And I think that's a hard thing for patients when they say, hey, I've got a response on drug. Do I really want to hold the drug, and I think a lot of investment in understanding how this drug works and how the drug holds are encouraged really goes a long way.
Yeah, I see. My practice has changed a lot. I tend to explore alternative dosing strategies with incorporating drug holds more commonly than I am, dose reductions, because I think that in my mind, at least, the AUC, at least the exposure of the drug, can be sometimes greater just holding the drug for a while and not actually lowering the dose. So it's a whole new way of thinking about management of this as we use the second generation TKIs over what we did with the original group of them. But for both of you, I wanted to know if you could if you had any specific patient examples of where Cabometyx just was saved the day. And, obviously avoid anything that's patient privacy or HIPAA related, but anything that you could share there. And then along that lines, how are you approaching the sequencing of Cabometyx in your practices, especially when it comes from, if you start off with another agent, an IO-TKI first line that is Cabometyx, and that's going to influence what you use later. And then if you don't use Cabometyx, what are you using along the lines of second, third, and fourth line? So remember, two parts of this is great patient examples and experience of where it saved the day, and then how are you sequencing? So let me throw it to Dr. Matrana first.
Yeah, absolutely. I mean, we have a ton of patient examples in which patients came in with highly symptomatic disease, bulky disease, so on and so forth. We got them on first line Cabo-Nivo, and they responded really beautifully. So we have tons of those examples. We also have examples of where Cabo saved the day in terms of a salvage therapy. Maybe the patients had not responded to a second or even a third line of therapy, a first line, second, third line of therapy, and then Cabometyx kind of came in the back end. Not seeing so many of those these days because we're using it, up front so much. And I know, as far as sequencing, you mentioned the pedigree trial, and I try to enroll every patient I possibly can that's eligible on the pedigree trial. I really like the idea of it's almost cheating a little bit because we want the triplets, we can't have the triplets, so it's a way of kind of getting that in of using that Cabo Nivo as a maintenance after Nivo Ipi in many ways. And we even do that sort of off trial as well for a lot of patients, right? All of those drugs are approved. And I think the advantage that you get from that is that, Nivo Ipi has a great duration of response. Nivo Cabo has a terrific response rate, and I'm trying to get the best of both worlds by combining those two. I really like to start with a Nivo Cabo in the first line. My go-to second line, for whatever reason, Lenvima Fenitor. I like it because it brings in that mechanism of action, that mTOR mechanism of action that's different from what the patient's already seen in the IO-TKI. We used to do a lot more IO-TKI sequencing. We don't do as much of that anymore with new data. Maybe it's suggestive of IO after IO not being as efficacious. And then, third line is kind of anybody's choice. I think we're doing more HIF these days, enrolling patients on trials. We might use another TKI, a salvage TKI at that point, axitinib, pazopanib, or tivozanib. But that's sort of our approach.
Great, excellent, thank you. So Dr. Serzan, what's going on up in Boston?
Yeah, lots to talk about. I think that to the first question, a patient that came immediately to mind was a gentleman who had a sarcomatoid kidney cancer, who treated with Ipi-Nivo as first-line therapy. He had a really nice response outside of the kidney, so we said, let's do a cytoreductive nephrectomy. And unfortunately, 3 months after his cytoreductive nephrectomy, he had recurrence of disease within the peritoneum and had a tumor bowel fistula, such that he was losing blood. You could see bright red blood in his stool, hemoglobin of 7, and met him inpatient on one of the higher floors of the Brigham and Women's Hospital, and said, hey, we really need to get control of disease. Wrote cabozantinib 60 milligrams, even though he was very weak and in a really tough space. And remarkably, over the next few days, his GI bleed resolved, his functional status improved, and now 6 months later, he remains on cabozantinib 60 milligrams. And so I think really speaks to the strength of the drug there, and the ability to get that early disease control. And we're certainly hopeful that we'll get the durability of that as well. The second note on sequencing, again, for that patient who needs response, Cabo-Nivo is certainly my go-to first-line therapy. I like that it has activity in liver, lung, and liver, bone, and brain metastases. And then my second line in that circumstance would be lenvatinib everolimus, just because of that dual drug synergy. third line, that's where patients have probably seen a lot of TKI, have seen a lot of TKI toxicity. And that's where I think newer drugs like cabozanib and or belzutifan really fit in. And so that's kind of my way of sequencing drugs, but obviously there's many clinical trials investigating new combinations that I'm quite excited about.
Great. And before we jump into some of the future directions and implications for CABOMETYX as we start integrating newer therapies, wanted to get your take on some of the long-term toxicity issues. We have a group of patients that respond well to cabozantinib and are able to stay on it long terms, and I'm sure we all have a few of those that pop into mind that have been on it for several years. And one of the things that I've seen happen is this sarcopenia, where there's this slow decline, loss of muscle and tissue, and sometimes patients will actually tell me they feel good. They don't necessarily look good, but there's a pastiness that develops to them, and they just get small. Is there any guides into that to help with management of that, or have you had similar situations on your long-term people having benefit where you see these kind of weight loss and other things going on? So either one of you, have you had any of that?
Yeah, I mean, absolutely. And I think, you really try to take a multidisciplinary approach. We involve nutrition. We, have a complementary medicine clinic that does things like acupuncture and things to help control pain. Of course, palliative, medicine, getting them involved early, not when you're thinking, end of life care, but really early. And so you can control symptoms better. I think you have to really kind of take an all around approach to maintaining quality of life and knowing that the disease is driving a lot of this. If you can get the disease under control, a lot of times, some of this also improves. So, getting them on the most efficacious therapy, making sure they're actually compliant and taking it, getting the toxicity managed, and then supporting them with all of the supportive services we have, I think is the best way to approach it. A multidisciplinary approach, so you're attacking it from every angle.
So what do you think, Dr. Serzan? Any pearls for the community oncologists and others on managing some of the long-term side effects in responding patients?
Yeah, couldn't agree more. I think the two specialists that I work most closely with are our nephrology folks. Obviously, many of our patients with kidney disease and being on TKIs long term can have hypertensive issues, can have chronic kidney disease issues, can have proteinuria, which obviously we check for early on, but then maybe as patients kind of settle into a dose, maybe don't check quite as often. So I think that's something that's super important. And then our nutrition colleagues are really fantastic as well. So making sure that our patients are having high protein diets, and the last plug I'll put in is also for our complementary and alternative medicine program, which does all kinds of exercise interventions and wearables and all kinds of things to make sure that our patients are not only living a long time, but living a good quality of life. And I think that's something that, graciously, many of our drugs have been able to help our patients do that. But I think as an oncologist sitting in front of a patient, it's not always the first thing that we're asking about, but something that our support staff can certainly help to champion.
Sure. Now let's move into kind of the crystal ball. We've got some meetings coming up, important meetings. We've got ASCO coming up, and we've got SITC coming up, and we've got ESMO. Where do you think CABOMETYX is going to fit in? I know it's part of various clinical trials that are looking at combination regimens, both combined as a single agent itself with HIF inhibitors, combined in cabo-nivo with HIF inhibitors as a triplet regimen. Where do you see with all, you can only answer within the confines of you can't share data that's not publicly around, but where do you think, or where do you hope CABOMETYX is going in the future, and how do you think these future trials will impact its use? Crystal ball, but no, don't share any secret data.
Well, I would say, I think combinations have obviously had a huge impact, and I think we're going to see more and more combinations, particularly with newer agents. I think we've just scratched the surface of what the HIF alpha inhibitors can do. We have it approved as a single agent now. I think you're going to see more combinations. of HIF alpha. I'm very anxious to see data on sequencing of combinations, pedigree, and the things coming down the pipe. I would say, point of frustration with some of the current clinical trials out there and some coming down the pipe are that I think our comparator arms are still very weak. I think sunitinib as a comparator arm was fine several years ago when that truly was standard of care in the first line setting. It's not anymore. And so in our center, our feasibility committee won't even approve a study using sunitinib as a comparator arm because it's simply no longer standard of care in the first line setting. And so, yeah, I'd love to see study designs with true comparator arms of TKI IO combinations compared to newer combinations.
Excellent. What do you think, Serzan? What do you feel is, I know you have many of these trials there at Dana-Farber. What do you feel is exciting and is going to change practice?
I think pedigree is going to answer a couple very important questions. And as many know, pedigree is patients treated with 4 doses of ipi/nivo, and then for those patients who have stable disease or a partial response, half patients are randomized to cabo-nivo, half patients are randomized to nivo. Really asking the question: does adding cabo earlier make a difference in the long run? And this is a huge study that's been done over many years, many sites contributing. And I think that's going to answer a very important question. I don't know for sure if that's going to come out this year or if the responses are going to be more delayed, but I think that's a very important question that's going to situate cabo in our treatment algorithms. I'm also very excited to see the combination of cabozantinib plus HIF inhibitors. We know that that particular combination targeting 2 different pathways within the HIF VEGF pathway with different toxicity profiles make that a very attractive option, especially as a salvage agent for patients who maybe got ipi/nivo in the first line and need a quick response. We've seen that combination of cabo and HIF has very low rates of primary progressive disease, very good durable disease control rates, and then seeing what the long-term toxicity profile of those combinations looks like. And then maybe one third area that I don't think we'll see data on soon, but I think there's a lot of enthusiasm is in the neoadjuvant setting. So for patients with a large primary tumor, maybe with a tumor thrombus, where we're really trying to debulk the primary and get patients to curative surgery, that it looks like a very attractive space, and certainly one where we've seen non-small cell lung cancer, we've seen melanoma, we've seen colorectal cancer, we've seen a lot of enthusiasm for the neoadjuvant space, but we really haven't made that much progress in kidney cancer. And I kind of see cabo and other TKIs playing a prominent role there.
Great. And so biomarkers, what's going on at Dana-Farber in biomarkers?
So I think one of the more exciting biomarkers that we just saw data from GU ASCO was the KIM-1 molecule. This is kidney injury molecule 1, which appears to be both prognostic and predictive of response when looked at retrospectively in patients on CheckMate 214 who were treated with ipi/nivo. And the nice thing about it, it's a soluble biomarker. It's something that's low cost and that we can look at other data sets in. So that data was presented at GU ASCO this year, but then at ASCO last summer, we also saw KIM-1 and it's how it was both prognostic and predictive response of atezolizumab in the Emotion 010 adjuvant trial. So I think that's probably one of the more promising biomarkers we've seen. Some of the other work that has been done has been looking at RNA signatures, so angiogenic clusters, immunogenic clusters. And while there's some really intriguing biology there, when we looked across data sets across large phase 3 trials, it doesn't seem to predict response to one therapy or another. So there is a study being done, the OPTIC RCC study, which is randomizing patients based on their RNA cluster score to either ipi/nivo or IO-TKI. And I think it's hopefully going to answer some important questions for us, but I still think we're a long way from using biomarkers to make treatment decisions in kidney cancer.
I would agree, and at the risk of sounding like a curmudgeon, I always say that biomarkers in RCC are like the holy grail. Everyone's looking for it. No one's really found it yet. And my whole career, I've gotten excited about this biomarker. I've gotten excited about that biomarker, and it never sort of really pans out. So I just, say I'm going to just take a back seat, and I'll believe it when I see it, when it's truly there, because I just don't feel like we've found the PSA of RCC yet. And maybe one day in my lifetime, but I don't think we're ready for prime time.
Yeah, I'll take a stab at just one of my hopes for the future is that where I see an unmet need is that we've certainly pushed CR rates, and we certainly need to understand the CRs and can we stop therapy and how that looks long term. But that we're only accomplishing that in still a minority of patients, and a lot of our patients, thankfully, with the IO TKI combinations, of which cabo-nivo is a powerful one. Cabo does such a great job of shrinking tumor and volume reducing, but we're still left with reaching that nadir within 3 to 6 months of therapy. And this old dogma that you just have to keep people on therapy until unacceptable toxicity to disease progression when they've nadired out seems a little ridiculous. And I would like to see novel trial designs where at that point of maximal tumor shrinkage that we maybe add in something or switch gears and stop. And we just never got there yet with trial design, but I'm hoping with some of the newer generation therapies, some of these T-cell engagers and CAR T therapy and just awesome novel therapies that we're able to bring in something at that point and continue to work. And I hope I champion, and I'm sure you guys are in agreement, that we may need to start looking at some novel trial designs instead of doing it the way we did, 20 years ago with cytotoxics. But as we end here, I want each of you to give a chance to just a couple key messages, you would, or practical considerations when our colleagues are using Cabometyx that you want them to take away from our brief roundtable today. I'll start off with you, Mark, if you want to throw out a couple key messages.
Absolutely. So I think, it's an incredibly versatile drug, has great efficacy in combination with IO. It has really changed the paradigm of how we treat this disease and also the outcomes that we can expect from the disease as well. That said, you have to manage the toxicities. I loved what you said, Tom, about the drug holidays and taking the drug holidays. We get really creative with dosing. If I have a patient, they say, I take this drug for 5 days and then I have diarrhea. We'll stop at 5 days and don't take it the 6th day. It's very practical how we manage this. That said, the dose reductions, the drug holidays, really vital in order to get people to be able to stay on this and have a decent quality of life. I think that's it. Those are my key points.
Okay, so what's going on there, Sammy? Sammy? I'm seeing a DNA echo. Do you want to mute yourself, Mark, and maybe Michael can go see if I mute myself.
Am I going to echo?
Well, where I guess we're all.
Oh, I think that might be better.
Okay, very good.
Excellent. So yeah, I'll just point to, I think we've seen over the past 10 years, we've seen so much data in clear cell and non-clear cell kidney cancer supporting the use of Cabometyx. And across that depth and breadth of experience, it's shown itself to be a very effective drug. We've obviously had a number of FDA approvals leading to NCCN guidelines recommending this combination. But even those studies that didn't pan out, where, Cosmic 313, although positive, definitely informs our clinical practice. I'll also point to the Contact 03 study, which was second-line cabozantinib versus cabo plus atezo, which again was a negative trial, but I think we learned a lot about how to treat patients in the second and later lines of therapy. And so I think we've learned a ton using cabozantinib. It's certainly, as we've all said on this call, a workhorse in our treatment algorithms, and something that I'm excited to offer to my patients and to work with companies at developing new combinations that are hopefully going to be even better in the future.
Well, thank you both for spending almost 40 minutes talking about cabozantinib and and we appreciate that. And then hopefully, I think the team is going to transcribe what they think is reasonable for both the print version, and then put something together that makes us all look beautiful and sound great for the video version. And if I see you in Chicago, come up and say hi. But I appreciate your time.